Hey, this is Jessie Manuel, and this is my geriatric syndrome presentation on dementia for older adult nursing course 5013. Introduction. First, I want to give a couple of definitions for dementia. According to Alzheimer's.org, dementia is a decline in mental ability severe enough to interfere with daily life. And according to healthyaging.org, dementia, most simply, is a memory problem significant enough to affect your ability to carry out your usual tasks. Some background and significance to consider. The two most common types of dementia are Alzheimer's disease and vascular dementia. Alzheimer's disease is the most common type of dementia, and it accounts for 60 to 80% of all dementia cases, whereas the second most common type of dementia is vascular dementia, and this can occur after a stroke because there was obstructed blood flow to the brain. For most of this presentation, I will be looking at dementia caused by Alzheimer's. I wanted to share some pretty significant statistics. First, Alzheimer's disease is the 6th leading cause of death in the United States, and nearly 1 in 3 seniors die with Alzheimer's or another form of dementia. This is not necessarily saying that dementia was the cause of death, but when the patient passed, they had a diagnosis of either Alzheimer's or dementia. In the United States, someone develops Alzheimer's every 65 seconds, so about 1 a minute, and current estimates show that 5.7 million Americans have Alzheimer's. This is very significant for the nursing profession because the number of people with Alzheimer's is estimated to more than double to over 14 million Americans by the year 2050. We will need more nurses to care for these patients, and we will need more providers to care for these patients as well. Subjective data. The patient that I met in clinical that I'm using as my example patient for this scenario was a 77-year-old female. She had no known allergies. The medications that she was on included atorvastatin 10 milligram tablets by mouth at bedtime, Eliquis 5 milligram tablet by mouth twice daily, lisinopril 10 milligram tablets by mouth every day, metoprolol 25 milligram tablets by mouth every 8 hours, and sotalol 80 milligram tablets by mouth every 12 hours. My patient was current on her immunizations. She had already had her flu shot in October. She had had both of the pneumonia vaccines, the first of the series in 2015, the second in 2016. She had a shingles vaccine earlier in the year in 2018 because she did have a history of chickenpox as a child, and she also had had Tdap within the last 10 years. The health maintenance and disease prevention activities that my patient participated in included walking 30 minutes every day at a local track near her house. She also did strength training by lifting weights twice weekly at the local senior center. Her primary medical history included high cholesterol, high blood pressure, AFib, and she also had history of a stroke. Hospitalizations, she was hospitalized when she had her children, one in 1963, one in 1965, and when she had her stroke in 2014. She had no other surgical history. Her current living conditions, she lives with her husband in a private residence. Subjective data continued. Patient presentation. Typically, the patient will present with memory loss, confusion, disorientation, and cognitive dysfunction. Common complaints, they will vary based upon what stage of dementia or Alzheimer's the patient is in. The patient or family member may report forgetfulness, personality changes, depression or anxiety, agitation, wandering, or even sundowning. My patient presented with both memory loss and occasional confusion. Her daughter brought her to the appointment, but at one point she forgot and thought that her husband was waiting for her in the lobby. Her daughter reported kind of ongoing forgetfulness, and she was afraid that her mother might leave food cooking on the stove and forget about it. For a patient like this, a full review of systems would need to be done, and it may have to be obtained from the family member if the patient's not able to tell you everything. Special attention should be paid to psychiatric, neurological, and endocrine so that any other medical conditions can be ruled out. Pertinent negatives would include depression, delirium, and any systemic causes. In the review of systems with this patient, under neuro, she was positive for memory loss. On to vital signs. Once again, this was a 77-year-old female. Temperature was 98.6 oral. Heart rate was 74. Her oxygen was 98% on room air. Her respiratory rate was 18. Her blood pressure was 130/80. She was 5 foot 2 inches tall and weighed 150 pounds, which put her BMI at 27.4 and put her in the overweight category. For the physical exam, the patient was alert, she was in no acute distress, and she was cooperative. Eyes were conjunctive pink, no scleral injections or icterus. Ear, nose, and throat. Posterior oropharynx was not red. There was no exudate, no thrush. There was normal external inspection exam of the ears and nose performed. Respiratory, CTA without wheeze, rales, rhonchi, and no accessory muscle use was noticed. Breathing was unlabored. Cardiovascular, she did have an irregular rhythm. The patient does have AFib, but no murmurs, gallops, rubs were heard, and there was no lower extremity edema. Her abdomen was soft, non-tender, non-distended. There was no rebound tenderness. There was no guarding. Neurologically, cranial nerves 2 through 8 were intact. She had normal sensation. Musculoskeletal, there was a normal exam of the head and neck. Skin was normal. It was warm. There was no rashes, no lesions. Psychiatric, she was oriented to person. She did have a little bit of confusion. There are various screening tools that can be used when you're looking to decide if a patient has dementia or Alzheimer's. One is the Global Deterioration Scale for Primary Degenerative Dementia. This tool lists 7 different stages of dementia, and the caregiver or family member who is with the patient the most compares the behaviors that they have observed in the patient with the clinical characteristics listed on the form, and this gives just a basic idea of what stage in the disease process that the patient is currently at. A second screening tool is the Mini Mental State Exam. This basically helps to estimate cognitive impairment, and it can also be really helpful because it can be used to document changes over time because you can compare previous scores to current ones. This actually looks at attention, language, memory, orientation, and visual spatial skills. A third screening tool is the clock drawing test. This screens for neurological problems such as Alzheimer's and dementia. With this test, the patient's going to draw a clock, and you're going to give her a specific time, and she's going to draw that time on the clock. Multiple ways to score this test include giving a point for every correct answer, or the more simplified way is basically to give 1 point if the task was completed correctly. So a normal clock would indicate the absence of dementia, while an abnormal clock would indicate the need for further evaluation. A fourth screening tool is the Short Portable Mental Status Questionnaire. This has 10 questions, and it covers orientation, memory, and serial subtractions. Incorrect responses are counted. If there are 0 to 2 errors, that means normal mental functioning. If there are 8 or more errors, that means severe cognitive impairment. For my patient, both the mini mental status exam and the clock drawing test were done, and both tools showed evidence of some mild cognitive impairment. Some diagnostics can be used when trying to diagnose dementia include CT, which could visualize vascular infarcts, MRI, which could help to rule out other medical or neurologic conditions, and some investigational diagnostics, which are still being used in trials, include PET scan or biological markers. Appropriate labs to run are going to include CBC, electrolytes, glucose, BUN, creatinine, liver function tests, thyroid, B12, folate, syphilis test, and urinalysis. Treatment plans for a patient with dementia or Alzheimer's can include psychotherapeutic interventions such as behavioral therapy, reality orientation, and exercise, social interventions such as functional and safety assessments, family interventions such as caregiver training and respite care, and also pharmacotherapy, medications that inhibit the breakdown of acetylcholine in the brain may help to improve or delay memory decline. An example would be Aricept. Also other medications, the NMDA receptor agonists that help regulate glutamate in the brain. An example of that would be Namenda. With the patient that we saw in clinic, she and her daughter did decide to start the lowest dose of Namenda. Differential diagnosis that could be ruled out. Brain tumor could be ruled out with MRI. Thyroid disease or B12 deficiency could be ruled out once her lab results come back. As far as final diagnosis, a diagnosis of Alzheimer's can only be confirmed upon autopsy. So presumptive diagnosis is made based on diagnostic criteria. This includes cognitive deficits that cause significant social and occupational dysfunction, significant decline from previous level of functioning, gradual onset, continuous decline, cognitive deficits that are not due to any other central nervous system, systemic, or substance-induced conditions, not occurring during delirium, and not accounted for by another psychiatric disorder such as major depression or schizophrenia. Challenges and barriers that are going to come up with a diagnosis of dementia or Alzheimer's are going to include medication compliance, and as the patient continues cognitively to decline, there could be other things. If a patient can't remember to take their medication, they may get to the point where they don't remember to eat or drink. Then quality of life may come into consideration. You have to consider the patient's autonomy and what they wanted. Would they want feeding tubes? Would they want artificial nutrition? Community resources that are available. There's lots of things through the Alzheimer's Association, and we did give the patient's daughters information. They have a 24/7 helpline. They have local resources, support and education programs, online resources, and also safety tips. For a patient like this, there's going to need a multidisciplinary team. This is going to include our primary care provider, her cardiologist for her AFib, our neurologist, possibly geriatric psych, her caregivers, information about respite care for those caregivers, and if it comes to end-of-life care, information about hospice, and as needed, physical or speech therapy. When discussing with this patient and her daughter, we looked at specific health behaviors that she already has or needs to address, including diet, exercise, and medication compliance. We looked at certain social determinants of health that affect this patient. Those include resources to meet her daily needs, access to health care, transportation, social support from her family, her literacy level, how much she actually understands about her condition. Other things to consider would be socioeconomic cultural issues. That's going to include disease burden, resource availability, and also cultural considerations about what type of care the patient wants and will accept. Legal and ethical issues to consider. There's going to be a loss of independence as the cognitive decline continues. The family has to look to see if they have the finances in order to care for their mother at home, or if she will need to be placed in a facility where she can be safe. And also end-of-life care would need to be considered when it comes to that. In conclusion, some things I learned while researching dementia are that risk factors such as age and genes cannot be changed, but that lifestyle changes can be done in order to help reduce the risk of dementia. Patients need to avoid preventable risk factors such as smoking, alcohol, unhealthy diet, and physical inactivity. There are also some medications that may help slow disease progression, but they will not reverse it. Cognitive testing should be used to measure progression, and also patients should be encouraged to make decisions about what kind of care they want before their cognition becomes impaired. These are my references, and I appreciate you taking the time to listen. Thanks.